Yeah, okay. Then, good afternoon, ladies and gentlemen. First of all, I would like to express my gratitude to the organizers for inviting me to this outstanding meeting and that I had the opportunity to share the podium with Professor Mansia. The title of my first talk today is Which Numbers for Hypertension Definition and Why? Well, this is a very exciting title if we consider what I have been listening in the two previous presentations. That even that we have studied hypertension for many years, there are many things that are still to define and still on conclusion. And I love it to start this issue with this definition of hypertension. This is a definition for Heffer Rose that say hypertension is that blood pressure level above which detection and treatment do more good than harm. And it is clear that which numbers and from which source to consider is the elephant in the room of the hypertension diagnosis and their consequences. Elephant in the room means that everybody knows that we have among us, but nobody knows exactly how to solve the question. And in this case, well, we have something on some ways to minimize the challenge, that mainly standardization and number of measurements and how and when, trying to validate the devices and also to consider at the same time the level of risk. But of course, in number of measurements, the guidelines driven a lot of information about that. This has been reviewed by the first speaker, that in which conditions the guidelines also recommend, and also we have protocols for device validation and that also charts and scales for the level of risk. But in all of this, I am going to touch mainly in the blood pressure figures. And for this, we need to consider, if we take in account the last guidelines that has been released from 2017 until now, there are 4 main guidelines that are not all in agreement. They have areas with differences. And one of the first differences in between them is which blood pressure to measure. And if we consider what are the blood pressure measurements abroad, is in one way we have office blood pressure, unattended or not. This is not the issue for today. That's ambulatory blood pressure, out of office blood pressure, and also central, as has been named before in one of the questions. For all of this, we need to take in account several things. First of all, it's affordable for one problem like hypertension, that this is quite common over the world. The values that we obtain with this change by treatment. It is possible to detect a change in treatment. It is giving us prognostic when we are assessing the patients the first time that we are seeing, the first time that we are diagnosing them. It's giving us prognostic value during the follow-up, changes in the follow-up is giving us also changes in prognosis. And finally, and I think that one of the most important, if we target these values obtained in office and ambulatory and central, we are getting more benefits that targeting ones against the others. Well, if we go to the office, that we have more experience for many years. It's affordable, change by treatment. We have a lot of data and prognostic follow-up, and also the majority of the trials has been targeted. But if we move to ambulatory blood pressure or out-of-office blood pressure, we have multiple measurements in home or 24 hours, and also we are able to measure during the sleep. We can assess intrinsic variability, circadian variability. We can obtain blood pressure values that has been related better with the presence of organ damage and with the long-term prognosis. But we arrive to the last point that I raised before. no evidence that ambulatory blood pressure or home blood pressure guided can obtain greater reduction in morbidity and mortality than clinic-guided therapy. Then we have this. It's affordable in many places, but not in others. For this, I put here a yellow one. But change with treatment, all this prognostic, but has not been targeted. What about central? Central was one question in the to the first speaker. Is not too much affordable. It is true that change by treatment seems to be that we'll have some prognostic at baseline, not too much, but there are no data that prognostic and follow-up and has not been targeted in order to detect if targeted central blood pressure, we can obtain better benefits in terms to reduce morbidity and mortality. Then we have these three ones, but are going to move right now to the values. Again, the guidelines have areas with differences. We have areas of differences in the concept to approach, in definition and classification, in the different risk assessment in equal, and mainly two, in the blood pressure thresholds and goals in order to define hypertension. At the time, and with more than to define, but not so much at the time to take decisions to treat or not to treat patients, as I will comment later. Well, first of all, you know that the European Society of Hypertension and Cardiology define hypertension in subjects that have blood pressure equal or higher 140/90. But this is not what has been that established by the American College of Cardiology and American Heart Association, that in the normative data, they define hypertension and stage 1 hypertension in equal or higher 130/80. This is translated to the ambulatory blood pressure monitoring. The guidelines of the European Society of Hypertension establish that ambulatory, that the thresholds to define hypertension ambulatory is daytime is equal or higher 135, the same that in home blood pressure, and consider normal in nighttime below 120. But of course here, there are also differences. You will see how the corresponding to the 130 in the American College of Cardiology, that is 24 hours ambulatory blood pressure monitoring. Then in this case, we have a controversial, and what is the impact of this controversial? For example, in Europe, if we consider the thresholds to define hypertension in 130/80, we can increase approximately 14% of hypertensive in Europe. In other words, we will pass from approximately 68 million of hypertensive in Europe to 76 from one day to the other. Well, where we can get information in order to try to consider what needs to be done in this gray zone in between 130 and 140. Well, we will get information for 3 points. First of all, for some clinical trials in which has been considered, this is the meta-analysis published by Tomopoulos and Professor Alberto Sanchetti, in which consider what is the relative and the absolute reduction in individuals with high normal or normal blood pressure, but considering the presence of global risk. And as you will see here, that for a stroke and for the combination and stroke of coronary heart disease, in those subjects with high or very high risk will be some beneficial impact. This is what has been done, has been obtained with the trials that has been performed in the last 20 years. One of the last and big trials also in patients with low to moderate risk subjects, that this is the HOPE-3 trial, have another information here, is that only subjects with higher systolic blood pressure higher than 143 millimeters of mercury have beneficial impact in the first co-primary outcome and also in the second co-primary outcome. In other words, only subjects with systolic blood pressure higher than 143 millimeters of mercury get benefits to receive antihypertensive treatment. But there are another interesting data that are coming from the real world data. And in this case, this is one paper published last year in New England Journal of Medicine that get data from the case permanent register in the Northern California in subjects higher than 18 years old, and they get 2.6 million of people that were enrolled during 10 years and then were followed during 10 years of this, were followed that 1,700,000 subjects. And in those that have enough minimum blood pressure measuring criteria was 1,300,000. What was the result of this? The first is that to consider what is the classification according if we use the classification of the American Heart or the European Society of Hypertension. Then, of course, it's clear that the percent of normal subjects is greater, much greater than those if we use this classification. I told before that there was an increment of 40%. But what about events? You will see here what is the risk according to the quantiles of systolic blood pressure here. Then the risk increases in the subjects who have 140 over 88 millimeters of mercury. In other words, then seems to be that based on the trials, based on the hope, based in this real world data, that we can arrive at some agreement. Well, but at the time, independent of the definition of hypertension or no, there is some agreement in between the two sides of the Atlantic. If you look here, this chart from the European Society of Hypertension and Cardiology, you will hear what need to do according to the blood pressure. In this case, below 140. Here is grade 1, grade 2, and grade 3. And then you will see here will be the thresholds for the American College of Cardiology and American Heart. And here is the threshold for the European Society of Cardiology. But the recommendations of the European Society of Cardiology is that in high normal, lifestyle advice, but consider drug treatment in very high-risk patients with cardiovascular disease, especially with coronary artery disease. Then I would like to finish here. I suppose that will be many questions, and questions will be in combination with the other presentation of this table, of this session. But I would like to stress that office blood pressure is still valid to diagnose and manage hypertension. That blood pressure 140 over 90 will be maintained as the threshold to define hypertension. This is the opinion that have in the European Society of Hypertension. The high normal blood pressure with high risk should be considered to initiate antihypertensive treatment. Out of office, home, is useful for follow-up antihypertensive treatment. And out of office or 24 hours is useful in many conditions. But I back to my comment of before. We need to get more information in order to be sure that targeting out of office blood pressure is beneficial to the patients in terms to reduce morbidity and mortality. And as Professor Mancia mentioned, there is one trial that is driven by Professor Parati, that is member of the European Society of Hypertension, that it is trying to identify if this is true or not. Thank you very much for your attention.
Thank you, dear Professor. Is there any question from the floor?
Thank you for your presentation. My question about the target of the blood pressure control. All the guidelines mention the target according to the comorbidity. My question about time to target. We speak nowadays about time to target. It is important to achieve the target in a short time to get target organ protection. What's your comment about time to target?
Well, it's what is recommended by our guidelines is that the target will be achieved in the first 3 months of treatment. In these 3 months of treatment, you need to have blood pressure under control. I didn't speak about that control. I will speak later in my talk about the kidney. I will go to speak about what is the target in the kidney, to protect the kidney, that this is maybe is the more conflictive at the time to take decisions in that. But of course, as soon as possible, but at least the maximal time, 3 months.
Thank you.
Thank you, Dr. Ross, for this wonderful lecture. Isolated systolic hypertension. I think it's missed here in the guidelines. You didn't mention it.
Sorry, I will I will say to you that sorry, follow the question, please.
No, I'm just you know, I understand from your lecture, yeah, there's different guidelines, but actually these emerge between European and Americans. We have to reach target, and everything is clear with 3 or 4 tables. Regarding the isolated systolic hypertension, which is sometimes is difficult to be treated, and how to treat it.
Of course, I think that isolated systolic hypertension, that in isolated systolic hypertension, we have the 2 extremes of life. We go to the most common, that this is in people higher than 55 years old, that usually that the target is the blood pressure, is the systolic blood pressure. Of course, that the risk, and we need to be careful when we have a very large pulse pressure. In this case, the reduction of systolic blood pressure should be achieved, but not in too much amount of medication, because if not, you can have problems. In the other side, that this is that has been named before, that in the young people, isolated systolic hypertension is still a problem. It's if you use central blood pressure, there are a large percentage of these patients, or these subjects, I don't say patients, these subjects that have a low central blood pressure, but there are others that are still high in high levels, of course. But in this isolated systolic hypertension in young, if you perform ambulatory blood pressure monitoring, there is a large proportion of subjects that have Y-code hypertension. And then I think at the time that you have a patient on this, if you don't have affordable for central blood pressure, start with ambulatory blood pressure.
Professor Redon, recently, in last January, there's published new guidelines in International Society of Hypertension that collect all the guidelines from Japan to the transatlantic to the States and Europe. And they put the mandatory and optimum. Do you think this International Society of Hypertension guidelines can cover all this dilemma and can control our patients? Because there is a conflict from the East, from the West. So what's your comment?
I understand that too many guidelines, the only that produces confusion. Yeah. This is true. If you try to put all together, at the end, you have a lot of things that are common. And the things that are divergent, sometimes, the majority of times are not real relevant. And as I showed you before, that if you consider at the time to treat patients, that in America, in the American College of Cardiology and European Society of Hypertension, is more or less the same at the end. The only difference is that they start to say hypertension in a large proportion of the population and then with lower blood pressure.
Yeah.
But at the time to take decisions to treat, at the end, it's practically the same.
Yeah.
Then will be a nice exercise to put all together. But I am sure that if you put all together, the core will still there present, and small differences, maybe not relevant, will remain there.
Thank you.
Thank you, Professor Redon. We will close this session and move to the next session.